Participation in this presentation is by express written invitation of the AHA only. Unauthorized participants and/or any parties that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call or log off the webinar if the AHA did not expressly invite your participation. Please note that you may submit your questions and comments at any time using the chat pod located to the right hand of your webinar screen. It is now my pleasure to turn the call over to Elisa Ares-Pacachaga. Please go ahead.
Thank you so much, Katie, and welcome to everyone. Good morning or good afternoon, depending on your location. Thanks for joining us for today's webinar entitled Cultivating Physician Engagement During the Pandemic, One Healthcare System's Physician Leadership Development Journey. I'm Lisa Ares-Pacachaga, as mentioned, Vice President of Clinical Affairs and Workforce at the AHA. And I'm really pleased to partner with Tracy and her team at the Leadership Development Group to bring you today's webinar. We're going to hear from a team at Northeast Georgia Health System as they share their journey to invest in leadership development. And I've partnered with Tracy for a number of years, and they always have such great sessions that they put together, so I'm really excited about this one. Two things to note, as mentioned, please enter any questions in the chat box. We'll be taking questions at the end. A recording of this session will be available on our website for those who participated later this week. So look for that if you need to refresh yourself on any of the details. And with that, I'm going to be quiet and turn it over to Tracy Duberman, President and CEO of the Leadership Development Group, to get us started. Tracy?
Thank you, Elisa, very much. And I would just make one other note, and that is please feel free to post your questions throughout the presentation in the chat box. I know that Elisa will be monitoring those, and at the end of the session, we'll leave plenty of time to have a dialogue about those questions. So thank you and welcome to the attendees today. Before I ask the panelists to introduce themselves, I want to take a quick moment to introduce you to the Leadership Development Group. I have the privilege to lead TLD Group, which is a firm deeply committed to developing physician and executive leaders and their teams across the healthcare ecosystem to execute strategy. Given your roles as physician leaders, we trust you'll find the session both thought-provoking and practically applicable to the work you do and the support you provide to leaders and teams within your own organizations. So now on to the panelists. Let's meet the presenters. Dr. Agarwal, let's start with you. If you wouldn't mind introducing yourself, including your position and role in relationship to the program that we're presenting today, namely Northeast Georgia Health System's Applied Physician Leadership Academy. So Dr. Agarwal?
So yes, I am Deepak Agarwal. I am the Chief of Medical Staff here at Northeast Georgia Health System, and I'm a nephrologist. And my role with this program was I was one of the designer and also one of the participants.
Thank you, Dr. Agarwal. Michael Covert.
Sure. Thank you very much. I am Michael Covert, and I serve as the Chief Operating Officer for the system. I've had the privilege of working with TLD before and have put together several different physician leadership development programs, all of them focusing on the applied approach to learning, if you will, and I've had great success in that regard, and we've had a great experience here.
Thank you, Michael, and it's been a pleasure working with you over the years and your commitment to putting physicians at the center of leadership within health systems. Dr. Hastings, please introduce yourself.
Yes, I'm Clifton Hastings. I'm a cardiothoracic surgeon, and I am the immediate past chief of staff, I'm thankful to be able to say. We served 2-year terms, and so I was chief of staff as we developed and designed this program. Then I handed over to Dr. Agarwal in January and helped him as we went through implementing the program.
Excellent. Tara?
Yep. Hi, everyone. I am Tara Satlow. I'm Vice President of Client Solutions at TLD Group. And for this program, I was the program manager. And by way of background, I am a psychologist, executive coach, an organizational development consultant, as well as a mother of 2 teenage children, and I use all of my skill sets in working with this team.
Super.
Okay.
Super. So,
Thanks.
Carrie, you're going to review the agenda, yes?
Sure, absolutely. So for today, the program, we're going to take you through the program impetus and design. So you'll hear about the COVID-19 pandemic and how it impacted NGHS and the decision to partner with TLD Group. You'll also hear about our organizational priority assessment process, the desired outcomes for this program that came out of that process, as well as the program design framework. And then we'll move on to a presentation of the findings and implementation, talking about the physician leadership competency growth, key takeaways, what comes next, and then we'll do Q&A.
Super. So we just wanted to spend a couple of minutes setting the stage for the journey that we took with Northeast Georgia and that we continue to take with them. So to set the stage, I'll pose a question to Drs. Hastings and Agarwal. And so opening it up to the two of you, it would be super if you could share a bit about your experience serving on the front lines of the COVID-19 pandemic at Northeast Georgia Health System. What was it like, and what was the general state of mind of the physicians during this period of time?
Well, I'll go first. We had actually just had a medical staff retreat with our board. We were having significant physician disengagement, and we were searching for answers as to what we could do. We discussed several options at this retreat. And as I returned home that Saturday, by that Saturday night, we canceled all our elective surgery because COVID was just beginning to hit us locally. We have had 4 separate surges, and they've been big surges. 3 of the 4 surges we've had to cancel elective surgery. As a cardiothoracic surgeon, much of what I do needed to continue, so we continued to operate. But our processes and the way that we ran our hospital was dramatically changed. We doubled the number of ICU beds. We added about 300 medical beds and have survived COVID. And interestingly enough, we're able to implement this leadership program in the midst of all of that, which actually, to me, was an advantage. But both Deepak and myself have been on the front lines taking care of patients and continue to see that day in and day out. We are fortunately on the decline of our 4th surge and are dipping down. We have about 100 less patients, so we got about 250 still in the hospital. But we are right in the middle of COVID here.
Mm. Dr. Agarwal, yeah.
So it has been, I mean, my experience has been, it has been out of the world. I feel like we have been on steroids every single day. We come in and feel like we are serving in a war. Your phone starts buzzing at 6 a.m. and doesn't stop till 10 p.m. And I hope, we never go through this again, and but it's just once in a lifetime experience. And during this time, to me, and also I think Dr. Hastings will agree, this was more evident to us that physician leadership, we really needed physician leadership to really lead us, our medical staff, through this crisis. And having to be able to have this program, it really helped us and really help us guide and bring us together. So yeah, it has been, once in a lifetime experience.
Yeah, I would just add that we did things we never thought we would ever have to do. We created critical care triage. We ended up opening spaces and having patients in gyms and hallways and treating patients in ambulances, which I'm sure many, many other systems have had to do as well. And it really, it took a toll on you personally. I've told people it's almost like a moral injury, or it almost hurts your soul sometimes when you see so many tragedies. But persevering through this and relying on each other, and supporting each other through this has strengthened us in many ways too, but it's still a huge struggle.
And one last thing that I would add is I have never witnessed this number of deaths on a daily basis. And we were facing anywhere from, our system before COVID-19 hit, we were accustomed to less than 10 deaths the whole month that we would lose. And now we were losing 10 patients on a daily basis. So it really took a toll on us, and it really took a toll on our medical staff. So I think physician leadership during these tough times we really needed that.
Yeah, and thank you for sharing that. And of course, all eyes are on states like Georgia. We're all hoping and praying that you're able to quell the spread of the Delta variant, and hopefully we'll be as a nation on the road to recovery. It's very interesting for us at the Leadership Development Group to be working with an organization through this extremely chaotic period of time, devastating period of time. And it is incredible that you prioritized investing in physician leadership development at this very time. And I think it will be really interesting for the audience to hear a little bit more about how we created the program utilizing the context of the situation that you were in, that the whole world was in terms of the pandemic and some of the challenges. So I'm going to turn the mic over to Tara, who designed the program with you, and she can take the audience through how we go about doing the assessment to create the program in a very contextual way. So Tara, take it away.
Thank you, Tracy. So yes, whenever we're brought into an organization, one of the first things that we do is an organizational priority assessment. And this is where we're interviewing key stakeholders. So for Northeast Georgia, it was 10 key stakeholders for physician leadership development. And the individuals we interviewed included CEO, COO, CHRO, and various other senior physician leaders in the organization. And we find that this process really engages people. It gives them a voice, helps socialize them to the program to know what's going on and how they're going to play a role in designing this program and weighing in on the content. So right off the bat, it's a great way to address the common frustration from physician leaders of feeling like they don't have a voice or a say in the decisions that affect them directly at work. So the kinds of questions that we asked, what are NGHS's most important strategic priorities over the next 1, 3, 5 years? What skills need to be developed in NGHS physician leaders to meet these challenges? How would you describe the relationship between physicians and administrators? And so by getting all of this information, we then analyze the results thematically, and that helps to inform the content of the program in terms of how we measure success, what barriers to watch out for, what the content of the learning sessions are going to be, the action learning projects, which we'll get to shortly. These are tied to the organization's key strategic priorities, and that comes out of these interviews, and what's needed for coaching. So the results of the OPA helped us cluster into 2 main areas, and that is the desired outcomes for the program. So for physicians to be able to lead and grow future leaders, they wanted project work that was meaningful and made a difference, so not just busy work, but very much tied to moving the organization forward. They wanted improvement in certain key metrics, that's physician and employee engagement, quality, safety, and throughput, and that they wanted a program that's engaging and self-sustaining. So some of the barriers to success that we heard about were, severe time constraints. So how do you do this program? It's difficult anyway under normal times, but throw in a pandemic, and time is certainly something that we took in great consideration as we designed the program. Selecting the right people, the right cohort, the engagement of non-employed physicians, working around the realities of COVID, the availability of staff, whether in person, virtual, and we ended up doing a hybrid of both, and a jaded mentality on physician leadership development, this sense of program du jour, and the perception that administrators won't walk the talk. So they don't actually get involved themselves in these kind of programs. So that was really helpful for us in just thinking about how best to design this program. And when we do design programs, we create a design team. And so for Northeast Georgia, it's folks from TLD groups. So it was Tracy, myself, and our colleague Jess. And then we partner with internal key stakeholders. And so for this program, we were really fortunate to have Michael, who's the COO, Dr. Hastings, and Dr. Agarwal, all who are senior leaders in the organization, who are part of our design team. And we meet weekly. I mean, we met weekly religiously, Fridays at 12 throughout the duration of the program. And that's where they were doing content, design work, logistics. So they really had skin in the game and were wonderful partners with us in designing this program. So a quick note about how we go about designing our Applied Physician Leadership Academy, or our APLA program. And we use what we call the 70-20-10 program model framework. And it's based on the adult learning theory research of Eichinger and Lombardo, and essentially says that the most effective way to learn is to have 10% of the program be didactic, 20% include assessment and coaching, and 70% be hands-on experiential learning, in which you apply learning and develop leadership competencies through work on real business problems, so in real time. So I'm going to pause here for a moment and turn to my NGHS colleagues on the design team. And Dr. Hastings, I'm going to start with you. A quick question. Can you talk about how you went about selecting participants for this program and what was important to you in designing the program?
Sure. Well, yeah, it was really a team effort between Michael, myself, and Deepak, and our administrative leaders within medical staff itself, and trying to recognize who our medical directors were, where we wanted to have a fairly broad mix across the organization, from primary care and specialties, as well as diversity on many other areas as well. And we simply sat down and made a list and talked about which candidates would provide the most enthusiasm and want to participate, and subsequently made a list of about 45 people. We narrowed it down to the top 30, and I asked them. We had about 4 who were not in a position, based on where they were in their life and with COVID itself, to commit to such a time commitment, because this was a 6 to 7 month time commitment, sometimes 4 hours on a Friday, and some people just couldn't do that. So we ultimately narrowed it down to 30 willing and very enthusiastic participants who were wanting to be a part of this. And we got some information from TLD to help them know and understand what the program was going to be like, and that created a significant amount of enthusiasm and desire to be a part of that. And that has only grown since we have successfully done this.
I might jump in there and add a couple of things as it relates to the selection of folks, because beyond what we were looking at in terms of mix of senior physician leaders, high-performing leaders, based on issues of the diversity and the things that you might go through, there were 3 other areas that I was looking for as well. People where we could focus on those areas where our physician engagement scores were lower, to engage those leaders so we could better understand why and involve them in the organization. The second piece was to look for individuals who also could be potentially of assistance to us when we established our goals for the coming year, and we can talk to you about that. And then the third, we did look at some who were serving in key positions but had very little management leadership activity or engagement or education, for that matter, besides the usual group that you might normally lean out to pull into a group like this.
Excellent. Thank you, Michael. So let's break that down, the 70-20-10 model. So starting with the 10%, the learning modules. When we do our learning modules, it's guided by the output of that OPA, the interviews, and that helps us identify what the content's going to be for these learning sessions, and then that's vetted by the design team. For NGHS, we held these in person. This was really important to this group of 30 participants. They were going to work every day during the pandemic, so they felt, we can continue to learn together in these large seminar, rooms We used an external conference center, brought them in. They must have been spaced like, I don't know, sometimes 15 feet apart in such a large space, but it was really important for them to be together. And the sessions include, interactive dialogue, case studies, business simulations, role-playing. We always include a call to action at the end of each learning session, to challenge the participants on how they can apply that in real time when they go back to their work roles. And it's led by our TLD group faculty. We bring in experts based on the topic at hand. And for one of the sessions, and we like to do this as often as we can, they're partnering with key internal leader, stakeholder in the organization. So, for example, for our business simulation, we had the CFO play a big role in the design and delivery of that exercise. So the content for the learning sessions is based on our physician leadership success model, which is an empirically researched model that we created a number of years ago. And it essentially has 4 core clusters: leading self, leading others, leading for results, and leading change. And interestingly, when we did the OPA interview assessment and we asked the question of what skills and competencies do you think would best benefit these physician leaders at NGHS, a lot of the words and concepts that were used aligned beautifully with this model, which isn't so surprising given that this model is based on physician leaders' input. And I also want to add that we use this physician leadership success model many times when we do our APLA programs, and we also design programs based on our, other clients have their own competency models that work just as nicely and ties the learning to specifically what competencies they're looking to develop within their organization. So for our purposes here, we took the input from this model, from the OPA interviews, and we created these didactic learning sessions. And here are the 5 topics that we ended up doing. We had one learning session under the leading self cluster that was about capitalizing on emotional intelligence to lead effectively. Another on leading for results, where we did a business simulation, building acumen and financial literacy, how to contribute to operational success. This is where we had an external facilitator come in. We broke the team into, about 8 teams of 4 people each, and it was a competitive business simulation where they had to run a fictitious healthcare organization's budget over the course of 3 years. Leading change, talked about population health and collaborating and building partnerships. Leading others, about adaptive leadership. And then we went back to leading self as the final learning session on resilience in healthcare and leadership. So a question to my design team. I'm going to start with you, Michael. As a design team member, what was the process of aligning the presentations to the organization's needs like? How did you work with the presenters to make sure the topics covered were impactful for physician leaders at NGHS?
Well, we sat down with them to specifically ask them where they believe that we needed to focus from their viewpoint as to what related to strategy for us. We've been going through a time in terms of real system development, particularly as we've added hospitals here to the organization, particularly as the medical staff has come together as one medical staff from all 4 hospitals at this point. We were not only looking at system development then, we were looking at growth relative to population health, and what did that mean for us in terms of the development of the number of lives that are being brought into the organization. How are we going to grow our service lines in ways that were meaningful at the same time? And how would we make sure that they were involved in that particular process with us? So it's a question of us sitting down actually with them to carve out the projects they would work on, how they would tie back to our goals, and how we could tie then also the work that they were doing in their educational sessions into this as well. There's one other piece that we haven't talked about yet, and that was the use of coaches and sponsors, if you will. We provided administrative support, I want to say this carefully, to each of the respective teams that were put together. The challenge for the administrative staff, however, is that they could help facilitate some, but they weren't to take over these sessions. They weren't supposed to lead this effort, and they had to be willing to be open to listen to these particular groups and to be of assistance to them because we knew that the goals and the recommendations that would be made would be coming from medical staff who wanted to have greater input into the organization. So we were very careful. I was very careful with the executive sponsors to be of support to them in the process.
Yes, and I definitely want to get more into the action learning component momentarily. Quick question in terms of the learning session, and I'm going to throw this one out to Dr. Hastings and Dr. Agarwal. Was there a particular learning session that impacted you, and why, for these didactic learning sessions?
Absolutely. And what I would say is all the sessions they all had a great impact, I think, on me, for me personally, and all the participants. All the 5 sessions were excellent. For me personally, the one that was building acumen and financial literacy. You know, as a physician, we're always wondering why can't the hospital administration just buy an equipment, or why can't we do something? But sometimes we don't have a deeper understanding of what that leads to. A decision, a big decision, how it can impact other areas. So again, for me, having just the clinical background and not having the business or the financial aspects to that I really enjoyed it. And now when I ask, or when I'm thinking of why the hospital cannot just go and invest something, I'm always looking at what else are they looking at and how it can have a domino effect on other aspects.
Yeah, that was a great session. For me, it was the very first session, the leading self, which was, we did a assessment, an emotional test, and we learned a lot about ourselves. I didn't realize I was as troubled as I was, so to speak. But in reality, learning about yourself was one of the key components of this, and then working with your coach to work on areas of strength, work on areas of weakness and such was key. But I want to add that really the weekly meetings that we had before and after each session, deciding where we were, what we were doing, what our needs were, we adjusted each presentation to some degree to meet our needs at the time and meet unique aspects of our facilities and our medical staff. So having the ability to provide input almost on the fly every week, because these sessions were usually 2 to 4 weeks apart, really created a very personalized experience for us, and we created presentations and solutions that were unique to us, and that was a key component in making this whole thing work.
Yeah. Thank you. So the 20% of that pie chart, that 70-20-10, so the 20% assessment and coaching, and again, we use that OPA interview to help us guide what's needed for assessment and what's needed for coaching, you know, whether it's individual coaching, dyad coaching, and which kind of assessments to use. So this is where we ended up designing as a design team for the coaching component of this program. So this stretched the 7 months from January to July. Each of the participants, and there were 30 of them, had a 6-month coaching engagement. They had an in-depth interview with their coach. They then used the results from their emotional intelligence assessment, the EQI 2.0 that Dr. Hastings was just talking about, to help them create an individual development action plan. That's their coaching plan that they're going to work across the course of the 6-month period. And they had 2 individual coaching sessions per month for the duration of the program. So question, let's see, I'm going to have this one start with you, Dr. Agarwal. Can you speak a little to the coachee matching process we worked through as a design team?
Yeah, absolutely. So, you know, we know our medical staff very well. And as everyone knows, there are so many different personalities that we have in our medical staff. So we looked at everyone who was going to be participating in this program. There were 30 of us. We looked at what their personalities were, and then we tried to match with the coachee to see, and we went through each one of them and looked at what they are best at, and tried to match each participant with the coachee, keeping again their personalities in mind. So that for us, that was a big factor. How to what coachee that each participant can really relate to, and we just didn't want anyone. We didn't want to pair up a participant and a coachee that we knew were not going to get along. So that was for us. That was a big factor.
Right. I think knowing our people and then reviewing the CVs and then relying on Michael's experience from before and then from y'all's experience and knowing your coaches, it was really a joint effort to make sure we lined up the right people with the right coaches. And I would say probably 29 out of 30 of those we hit a home run, and the one we didn't, we switched. So it all worked out really well.
Of course, that was neither one of you, of course.
Of course not.
Well, and since you both participated, Dr. Hastings and Dr. Agarwal, what did you personally find impactful about the coaching experience?
It was great. The first thing that I realized that I had no emotional intelligence that I really needed to work on. And I have to mention this, that when I told my wife that we're discussing emotional intelligence, she said, yeah, you don't have it. And I said, I don't have it. And she said, yeah, she's an HR. She said, you don't have any emotions and you're definitely not intelligent. So you will really benefit from this program. So I think my coach was Jennifer, and she was amazing, really dissecting the emotional intelligence test that we took. And some of the stuff I have always kind of, she really brought up some of the stuff that I was not able to recognize. So those sessions were very, very meaningful, and she gave me strategies how to work around it and how to improve those things. So that was really impactful.
I had a similar experience. Mine was, I learned a lot more tools for decision making and leading tools, and so I shared with my coach very personal things, as well as my wife also had similar comments about me, and she noticed a difference. And actually, she looked forward to my coaching sessions because we would talk about it afterwards, and she learned a lot from this as well. But the circle of change and a lot of other tools that were utilized helped me understand how and what I was doing, why I was doing it, and in many ways helped me make clearer and better decisions and much more confident in my abilities to do that by growing through that. So that to me was the best part of the entire thing, was dealing with the coaches. And I think that was a similar response from all the other participants as well. As a matter of fact, the majority of our people have extended on for another 6 months of coaching, even after we finished our cohort. So
yeah, and one thing I definitely want to add is the wellness or the happiness. It starts with you. And my coachee kept on asking me, "Are you happy? Let's talk about your wellness." And I kept on saying, "Well, I'm responsible for our team." And she kept on saying, "No, tell me about your happiness. Tell me about your wellness. What are you doing?" And it was kind of a foreign concept to me, because as a leader, I just want to take care of our team and kind of ignore my own happiness and my own wellness. And she basically emphasized that it really begins with you. If you're happy, this will resonate through the rest of the team. That was very, very important.
Yes, thank you. Okay, and then moving on to the 70%. So again, that 70-20-10 pie, the experiential learning. So for the experiential component of this program, it's twofold. We do what I was talking about earlier, the call to action at the end of each of the learning sessions, where participants are challenged to go out into, back into the organization and really apply what they learned in those didactic sessions. And then we do something called action learning, and this is a big part of the program. This is where we break the participants up into cross-functional project teams of 6 to 8 individuals each, and they're facilitated by an action learning coach. There are sponsors selected for each project team, and as Michael was talking about earlier, those were administrative leaders. So now you have the pairing of your physician leader participants who are on the teams, and then an administrative sponsor of the project who acts as a resource and advocate for the project's success. So they are not playing a role in the direction on where the project solution lies, but they're just there to help them move things forward and act as a sounding board. The project teams then report out on their learnings and their recommendations to each other and to senior leadership at a capstone event where their sponsor and action learning coaches are in attendance. So action learning focuses 50% on driving the problem to solution, and then 50% on the individual leadership development component that comes out of being part of this group and really taking a look at your own learning and development in real time. So I have a question for you, Dr. Hastings. No, I'm sorry, actually I want to start with you, Michael. When we create the projects for our action learning projects, we use the OPA interviews to help identify the key strategic imperatives for the organization, and then we translate them into learning projects. From the executive perspective, what were some of the important strategic imperatives that needed to be addressed in early 2020 in order for NGHS to succeed?
Well, remember what I talked about. We needed really to focus on three things in particular. One, I've already commented on some of the larger strategic system development goals that were important to us and that we really needed our physician leadership to be involved with on if we were going to move forward, particularly as it would relate to population health or service line development, as we talked about. The second really had as much to do with their involvement with us on the day-to-day issues, the goals relative to our performance in the safety arena or in quality, and how we would deal with issues of readmissions, how we deal with issues of throughput, and the relationships then that our physicians had with our nursing staff, because we knew that we really needed to do a lot of work in that regard. In essence, we had two silos rather than a joint group functioning together. And that was going to become important to us. The third piece of it actually just simply related to COVID. We knew that we were going to have potentially more than one surge, and how were we going to respond to that? And that we really needed everyone around the table. I will tell you where this really came out is when our doctors came together to talk about establishing a triage protocol and seeing what potentially could happen. Their involvement, their interaction with each other, their leadership became really important, particularly in not just for themselves, but in leading, the other 1,000 physicians that we have here that practice in our health system. And so all three of those areas required a focus and leadership that would be much stronger than what we had anticipated in the past. I also would tell you that through its use, I knew that we could help develop our administrative leaders as well, because their involvement with our medical staff was not, how do I put it, was very episodic, up and down. It wasn't consistently interactive with them. And we had issues of trust that we needed to develop. And the potential of these projects in bringing that together was a real opportunity for us. And I could comment to you about outcomes as a result of that. But these were all areas that were important to me if we were going to put a group together to help us lead this organization, not just now, but over the next 5 years.
Right. So with us taking that input and then us also taking the input from the organizational priority assessment, we received a bunch of recommended topics to do the action learning projects. And so the top four were, we did one project on decision-making, the idea of how do we consistently and meaningfully engage physicians in decision-making processes, and this gets really at the empowerment that you're talking about in the engagement and the involvement. The second was dyad partnership. How can we enhance dyads, that relationship between the physician leader and administrative leader, to drive engagement and performance metrics? The third project was patient throughput, again getting at that safety and quality. How can physicians unite to solve overcapacity issues? And then the fourth was performance. What physician performance metrics should be tracked to enhance our quality and safety scores. And, for action learning projects, there's certain criteria that you can see on here that we're listening for when we put them into a project. So it needs to be meaningful to everyone, cross boundaries and functions. This cannot just be like an emergency department initiative. It has to affect everybody across the organization. That reasonable people could disagree about the solution, that the action can be accomplished within the program timeframe, and that most importantly, participants are empowered to propose the solution. So it's a real testament to the confidence that the administrative leaders have in the physician leaders to say, these are 4 key areas that we want to move forward, and we want you to have a direct voice in leading and guiding and recommending what that might look like. So my question here for Dr. Hastings and Dr. Agarwal, who both were participants in the program, in the early days of action learning, there's often a lot of ambiguity and confusion. Can you speak to what that felt like as a participant and how the teams came together over time?
Sure. I can remember after our second session, everybody was looking at each other going, well, when are they going to tell us what to do here? And the reality was when the coaches and their administrative liaisons looked at us and said, it's up to you. You guys need to figure this out. That's why you're here. And the fact that we were working on projects that meant something to us, we were able to choose which of the 4 groups we went to. I liken it to someone telling you how to swim. All the other leadership experiences, I heard all sorts of lectures about how to swim and how to do this. In this particular exercise, they put us in the pool, and then at one point they dropped us in the deep end, and we sputtered around for a little while, but ultimately we helped each other and learned how to lead and come up with solutions together. So having a hands-on project, especially a project that meant something to you, was important. But they did let us struggle and let us figure it out on our own. If somebody went under and didn't come up, they did pull us out of the pool. But for the most part, we figured it out on our own, and that was very, very helpful and very, very good in learning.
Yeah, I mean, we were so lost in the beginning of the project, and I remember Michael coming in and saying, "You're supposed to be lost," and we were like, "So what are we supposed to do here?" And it was up to us to figure this out. And as both me and Dr. Hastings were assigned to DIAD partnerships, so both of us were in the same group. And one of the things that came out of this was we actually looked at all our DIAD partnership in our health system. We met and looked at who was where we had DIAD that existed and where it didn't exist. So it gave us a chance to look at all the DIADs within the health system. But towards the end, I can say everyone knew, we all felt great about the project, and everyone, all that ambiguity was gone by the time we were presenting these projects.
Yeah, which really mimics real world, right? The real work. When you're a leader in an organization and you have to take on an initiative and you've never worked on it before, there's a big learning curve. So I think just that skill set of understanding what do I do with this ambiguity and how do I infuse meaning into it to move it forward in the organization is that experiential, hands-on, real-time learning. So I'm mindful of the... Yeah,
there is one other piece to that, Tara, along the way. It required my actually having to come into each of these groups to share with them that, yes, we are committed, yes, we will follow through, yes, we are interested in your recommendations, nothing is off the table in that regard as you come together, and we'll put structure, we'll make structure out of this to follow through with your recommendations. And that's because, I think you still have those in the group who said, they're not going to do anything with this, so why bother? So that took a lot of time in and of itself to share with them that level of commitment, which we're actually following through with today that we can talk about.
Yes, and I'm going to ask you about that momentarily. So very quickly, this is just all of the components of the program put together in one space where you can see that there is that interwoven connection between the learning sessions, which are marked by the red flags, the action learning team meetings, which take take place monthly, and that's marked by the blue flags and the blue circles, and that the coaching goes across at the same time. So you're able to, as a participant, talk to your coach about what's happening in your team meetings and also be working in learning content from the learning sessions. Okay, so presentation of the findings. What did we find? We had great success with this program based on the data that we collected through, we did both pre and post test assessments, we did evaluation surveys, but for the interest of time, we'll only be able to look at a few illustrative findings. With that physician leadership competency model based on the 4 quadrants that I talked about in the beginning, we did a pre-program assessment. We had them all take the assessment at the beginning of the program. We had them take the assessment again at the end of the program, and we saw a nice improvement of scores across all 4 clusters. Here, this just shows you the light gray at the top shows you some clusters across the leading self, the self-awareness, self-management, and self-development clusters. Scores that are marked in green are above 4.5, so you can see a nice increase in scores. These assessments are based on a scale of 1 to 5. And we saw the same thing in our leading other clusters on building effective teams and communicating and inspiring. So I'm moving quickly here. I want to show you one more slide here, our overall program feedback. What I like about the cluster of questions here is it really gets at the outcome of the program and the impact overall. Again, scale from 1 to 5, and we're seeing in the weighted average, our scores are all, all above 4.5 in terms of agreement on these statements. And the one I want to point out is the question of the ultimate engagement question of, my commitment to Northeast Georgia has improved as a result of my involvement in the APLA program, and that's a 4.8. So really illustrating how impactful leadership development programs are for cohorts of leaders, for physician leaders, particularly at a time of crisis like COVID. Probably counterintuitive to most would be, we can never do a program right now. It's too crazy here. And what we found, and you'll see with our key takeaways, is that leadership development programs provide a way to stay focused on strategy and move forward through crisis. That the development activities, coming together for those learning sessions, coming together for those team meetings, really having to work on a project, and they put hours and hours into their projects. And coaching can all help physician leaders feel understood and empowered through crisis. The power of in-person connection on the front lines and investment in physician leadership development enhances organizational commitment. So my question to all 3 of you is, what have you noticed about physician leaders at NGHS post-program? What has changed, if anything?
So I'll go first. So I think a couple of things. Number one was we initially, every time when we were looking at our medical staff and to see who can serve in leadership roles, we were always struggling. And after this, or by participating in this program, what we realized was that we actually have a lot of great leaders within the program or within our health system. And who can really step up to the plate and serve in those roles if given the right tools. So that was one. And second was we really felt like we kind of leaned on each other. It created long-term relationships. And, through this crisis, we really felt that we were not alone. And we can work together and we can get through this. So I think those were very important, how we interact with each other and how we are responding to each other's needs has really changed after the program.
And I would just add that it seems like we're more willing to speak up, we're more willing to step up and to be a part of the process. The other thing is it also showed us in 1 or 2 instances where people who we thought were going to be great leaders basically looked at this and said, this really isn't for me. And it was helpful for us, but it was also helpful for them because they were frustrated that they weren't achieving what they wanted to achieve. And I think this helped clarify for them that maybe there's another talent and another place where they can contribute. So overall great interactions and great friendships created.
Yeah, no, that's great.
I think it's something that was a surprise is, we make the assumption administratively that all these folks know each other, and they really don't and didn't. And it brought people together, disparate areas of the system, and really created a cohesive group. You could see that in how we manage COVID, our use of resources. You can see it in terms of our medical executive committee, because as you heard, under the leadership of these two gentlemen, we have merged all of our medical staffs, and that's made a difference as well. So we have people that are leaning in to make this successful. I've seen a lot more volunteering. People come up to me and said, hey, I'm willing to get involved in that project, Michael. Where do I plug in to make that happen? And there's a strong commitment to make the dyad process really work. And they're at the table in a real positive way, and that's a change. And we've seen that even in the latest physician engagement scores.
Yeah. So final question before we open it up. We hand back over to Elisa, who will take us through questions from our audience. Michael, how have you carried forward the work that was done through the action learning process? Because I know those participants spent hours and hours with their recommendations post-program. How have you carried this forward?
I have a number of things that we're doing. One, we have literally built in their recommendations into our strategies for the next year. They are a specific part of our goals, and the physicians who have been involved with that are now serving as partners on those goal teams, things that had not happened in the past. We're working to now develop a dyad educational program for physician leaders and their dyad partners, and that's been really positive, the number of dyads that have stepped to the plate and said, look, we want to be able to do more and to be able to teach each other in that regard. We're establishing, at the request of our medical staff at their Reach and Retreat, a second cohort for our APLA program, and we may have the present cohort 1 leaders to recommend physician leaders and to be mentors in this next group. We've given the first cohort participants the opportunity to continue with their coaches for a second 6-month period of time, since that level of commitment is there. Several of our physician leaders have moved into medical director roles that had previously not been considered for such. They've stepped to the plate. We're creating a medical director position for physician leadership development. And we have an initiative at the request of these particular groups to look at all of our medical director positions to ensure that they have a dyad partner, that we have metrics that are measurable, that they can help to achieve. And we started an APLA newsletter, if you will, as this group has taken on a life of its own. Probably one of the biggest things that I've seen is the disappointment because they're not getting together every 3 or 4 weeks as we had, and so they've had me come back to talk about what mechanisms can we put in place that brings us back together in other ways, and can we do advanced coursework. And I never expected that totally out of the group that we had.
Great. Thank you, everyone. Elisa, I'm so mindful of the time, so I'm going to hand it over to you quickly for questions.
Thanks so much. What a great presentation. And I see we have one comment in the chat about you just answered the question. I actually had a question I was going to ask for those on the line who have questions. Remember, you can put them in the chat, but I'm going to take moderator's privilege and sort of ask my first question, which is, you talked a little bit, especially in this last part, Michael, about that connection between the physician leader and their dyad partner. And I'd love to hear a little bit about how you cascaded that sort of from leadership on down to really make sure you had that alignment and connection and camaraderie between the clinical teams and the administrative teams.
Well, let me say that we recognize, as a result of this team's work, all of what we were not in the way of dyad partners or issues associated with those dyad partners that actually exist in functioning together. If I'm truthful about it, we had 3 or 4 maybe really good dyad partner role models, and who knows how they develop them themselves. And they talked about the benefit. I think of perioperative services as an example, where I have a medical director and an associate medical director for our perioperative services and an executive responsible for it day to day. And they've come together in some tremendous ways that have significantly influenced the effectiveness of our ORs and our perioperative program. And they talk themselves about it. Same thing with the ED. And so what's happening is these leaders who have participated are reaching out to other dyad leaders to talk about their experiences and coming together with each other. And that's what's now led to their request that we actually put together a program to educate dyad leaders, and that we should expand the number of dyad leaders that we have in the organization. And so if you're listening carefully to this, I didn't have to do this myself and say, yeah, you know what, we need more dyad partners. You know, this has come from them talking to their peers. So it's taking on a life of its own.
I love it, and that's just a great way to do it. And for Dr. Hastings and Dr. Agrawal, I'm curious if there was anything that sort of surprised you about the response that you got from the medical staff as you came up with this. I can imagine some of the responses, but was there anything that you said, well, that was not what I was expecting?
The overall acceptance of this, I mean, we've previously had a lot of physician leadership and other programs and lectures and such that were well-intentioned but never were accepted like this. Once the people who did this got involved, I mean, you couldn't hold them away. They really have bought in, and they really benefited significantly from that. So the success, it was the biggest thing that surprised me. And more importantly, the people who I thought were the least likely to benefit ended up being many of the ones who benefited the most. So that was my surprise. Deepak?
Yeah, so I think so far there has always been, in the past, it has been, you have the administration making decisions, and we were always kind of standing out, looking in. And we were working in our silo, administration was working in their silo. So I think what really surprised us was that administration was really committed to this. All the administration leaders came to all the sessions, the didactic sessions, they came, and then they were part of our projects and helped us guide, and we leaned on them. So I think that was kind of refreshing and surprising to everyone that, listen, I think this is a great partnership and this is real this time. So everyone was kind of pleasantly surprised.
That's great. And just a reminder, if you have any questions for our presenters, just feel free to type them in the chat. It sounds like you all really, the commitment and agreement that this was important and shouldn't be trumped by what was urgent could not be clearer in the midst of COVID to come out with this effort, knowing the value it would bring to you, I think is just amazing to hear. I don't see any other questions, and I know we are just about 30 seconds from the bottom of the hour. So I just want to share my thanks to Tracy and her whole team, and to the team at Northeast Georgia for taking the time to share with us the great work that you've done, and hopefully inspire some of your colleagues to really build those bridges and make those connections.
Thank you.
Thanks for having us.
Thank you.
Thank you.
Thank you, Lisa, for the opportunity. Thank you.
Thank you, Lisa.
Bye, everyone.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now log off and disconnect.